Hello, hello. We got a crazy one for you today. So we sat down with Craig Liebenson. So we were in LA Spine and Sport, and man, what a cool little environment and a cool thing that they built there. So Craig Liebenson, his gold medal is no doubt, Brett, collaboration, bringing together lots of different people, which he basically exemplifies in his book, right? So Rehab of the Spine is one of the best collaborative books that we've probably ever seen, especially in our industry. And so understanding bringing things from chiropractors and strength training and PT and all those different worlds together.
Even in 1996, the famous Blue Book, when it came out, it was even before my time, but that was basically the Bible of rehabilitation at the time. And I mean, I remember just studying and memorizing that book. And Craig did a really good job at that time of starting to blend the worlds like you talked about. And I think, he gets credit for exposing, basically the Prague School to the rest of us. I mean, the Prague School is going to be great without everybody, but at least in the United States and Canada and, this part of the world, Craig Liebenson is the one who at that time had exposed everybody to that, which was even a little bit before my time.
Yeah, absolutely. Yeah. So what about, what are things that were so contemplated from this conversation, and what Craig kind of does in the clinic?
Yeah, it's been fun watching, Craig's career, myself watching, his career as it has unfolded. And I think the thing that, him and I have talked about over the years would probably definitely be like the blending of manual therapy with exercise, with just general exercise and motivating human beings to just go move their body. Mm-hmm. And Craig's probably definitely, admittedly, more in that camp probably at this point than we are. But I still am always really impressed, and Craig's very well spoken. So, in our model, it's about we need targeted rehab. We still need people, to be motivated to go move their bodies. Mm-hmm. And we still, we're more about precision, admittedly, at Gestalt. So, but, I always think of it like a Venn diagram, so we're trying to, take the best parts of everyone's model and do the best job we can of implementing that. So I thought Craig did a great job. And, like I said, it's always interesting to, hear him tell the Prague school stories too, because he definitely, was one of he was the first one to organize the group to go over there. So
it's pretty special. Without Craig Liebenson, we may not be exposed to everything that we are.
That's right.
We're super thankful for him, and we had a blast with him and had a good dinner that night, and had some great conversations on Venice Beach. So awesome. So anyway, guys, enjoy this conversation with Craig Liebenson, and we'll catch you next time. All right, everyone. Welcome to another episode of the Gestalt Education Show. Brett and I are delighted to be sitting down in LA with the one, the only Craig Liebenson. So we are here at LA Spine and Sport. We've obviously been following Craig forever. Brett's a little bit closer to him, but you've been a huge mentor to me, not only because of your books, but because of the work that you've been doing. And so we thank you for your service, number one, to the profession, and we can't wait to kind of dive into some of the things that make you who you are. So, Craig, maybe talk us. Let's start early on. So you were one of the first one to bring Prague to the United States. So talk us through how that all happened and kind of where that all began.
Jeez, what an intro. I got to take a step back and gather myself after that.
No pressure.
That's a really good question, and I think that it started with reading the works of Levitt and Yanda early on, and before that it started with a skepticism about chiropractic. So I didn't go to chiropractic school as a chiropractic believer. In fact, I didn't go to chiropractic school to be a chiropractor. I went to chiropractic school because I didn't believe that the medical model was having any kind of preventive emphasis or what we would call holistic emphasis. It certainly wasn't person-centered at all. And at chiropractic school, I was really lucky to be exposed to people like Kirkcaldy Willis, Yanda, Levitt, and people that were of a different mindset about person-centered care, and teaching people what to do for themselves. So when Levitt says rehab is self-management, that to me is the biggest game changer of all. So it's not us fixing people. It's not us doing to people and the person's passive. It's not passive care. It's what we show people to do for themselves. And so I was really lucky to be exposed to that and to invite Levitt and Yonda to America to join with people like Phil Greenman and Janet Travell and Kirkaldy Willis, Gunnar Anderson, other top orthopedic surgeons, Vert Mooney, Robin McKenzie, and get them in these multidisciplinary settings where we actually sold out our auditorium at the college in Whittier, in Los Angeles Chiropractic College. The first time we had a second room where we had a live feed for all the spillover. And there was no faculty in the room. 350 people in the room, not one faculty. And the Board of Regents was against us too.
You were a student?
I invited them when I was a student.
Wow, that's amazing.
So that was, and for a person with attention deficit issues, shall we say, I found myself listening to Levitt and finding peace. Like everything he said made so much sense. And for the first time as a student, I was at the edge of my seat and I had endless patience. So it was a career-altering experience where he not only lived up to expectations, but far, far, far exceeded them. And then following on that, like it was 87, we had Levitt, 88, we had Yonda, then Levitt came back a year later, we did a 5-day course, we tried to get people in the field to come, we tried to get faculty to come. It was very disappointing. There was minimal interest, and Levitt wanted to teach the teachers. And so we really weren't able to deliver. And he said, I'm 77 years old. He goes, I'm not coming anymore. And Yonda wanted me to go to Prague. So I had Yonda a few more times. We just flip-flopped all of Yonda's seminars. Evaluation and treatment of tight muscles, evaluation and treatment of weak muscles. No, can't we get both? Can't we get the muscle imbalances? Let's do hip extension and hip abduction and deal with the tight and the weak in the same seminar. So we kept trying different combinations, and people were mesmerized with the simplicity and the cookbook style of it and the algorithm of identify tight muscles, stretch tight muscles before strengthening weak. Little did I know that maybe we had it backwards, but that didn't matter, okay? But the Berlin Wall fell and off I went to Prague, so that was 1990. And then a few years later I started bringing groups of people over, and at one of those meetings is where Levitt and Yonda are sitting together. We're having an extended Q&A. So it was maybe the second time I brought a big group over there of people from all over the world. And Levitt started to expose the chinks in the armor. So long before Boyle and Cook had a couple beers and came up with joint by joint, with alternating areas of stiff and weak, long before FMS correctives, Prague School was already moving beyond the model that you address the mobility issues first. So if you look at the FMS and the overhead squat, the first thing you hear them talk about is the correctives for ankle mobility. That they don't have the depth, they fail the squat because of the ankle, and now you have to do correctives on the ankle, you have to mobilize. And I don't know if you're familiar with my interviews with Gray, but I knew Gray didn't believe what his dogma was suggesting. And so I asked Gray, I go, Gray, does finding a mobility deficit mean you have to correct mobility before you strength train? And you know Gray well enough to know that he literally is the son of a preacher man. And so the man can talk. So I had to bring him back 20 minutes later and repeat the question. And then I had to bring him back 10 minutes later, repeat the question. I had to bring him back 5. I'm glad you're going to have 3 days with him. And finally he said that it's about the goal, that it's not about the method. And if you find a mobility deficit, you want to see that mobility is restored, but you do not have to mobilize. And this interview was after FRC took off, where you were trying to inject chiropractic stuff about position sense and end range mobility, kind of like MDT does with McKenzie, into chiropractic. And it was hard to get him to talk about the goal. Yeah, we want the area that's stiff to be looser, but you may not have to mobilize, as long as the outcome is delivered. And so now we know, there's many roads to Rome. There's a lot of different entry points. If you're into core, if you're into shin box, if you're into ontogenesis, if you're into intensity, if you're into variability, if you're into Franz Bosch, it's complex. We can't say one thing is better than the other.
Sure.
Every person is different. One person is anxious and is overprotective. Another person doesn't know pacing, and they're boom and bust. Somebody else doesn't train for the game. They're a weekend warrior, and they think they're fit, but they don't do any training at all. Every person is different, so we want to do kind of like what Peter O'Sullivan would say, which is we want to get to know the person. We want to be insatiably curious about each person's story, and that reminded me of Levitt again, to go full circle to your question. What I learned when I went to Prague after the Berlin Wall fell was how much the history was a cornerstone for Dr. Levitt. And he would sit and talk to a person for over a half hour before he would ever examine them, to get their past history, to get their injury history, to find out about their childhood activities and sports, what they're currently doing, what their occupation is. It could be a musician. It could be somebody with an elbow issue. And he's digging into their childhood. Not psychology, but he wants to know as much about the person as possible, because that's where his muse is. And that's something that I think I forgot about. Like with Yonda, I forgot how important the feet were. I forgot how important the sensory afferents were to the motor output, and how important the sole of the foot was, normalizing afferents from the sole of the foot. I forgot for 20 years that was 90% of Yonda. Certainly wasn't stretching tight muscles. And he said that I was responsible for putting more emphasis on the movement patterns than he did. That they were just a pedagogical tool for him, for people like me to understand muscle imbalances, but he didn't use them. And you wouldn't get that if you were peripherally studying Yonda, but when you saw him work, he did gait assessment. You're in an airport with Yonda, you're at a restaurant, and he's reverse engineering the injuries of the waitress by watching how they move. So with Levitt, he talked about the history, and now I realize, 30 years later, my God, I got so mesmerized with my testing and my treatment or my training that I lost sight of what for Carol was the sine qua non, which was the person's story. And now we go full circle and we step forward to the future with cognitive functional training or cognitive behavioral training and the work of Peter O'Sullivan. And we see how much we get when we're empathetic, when we're curious and we listen to people. Then the rest is easy. They tell us the tests, because the history gives you the AIs. And you find out what are their lived experiences that are causing them duress or stress or anxiety or frustration or depression. Where have they gotten pessimistic about their future? What is it they value? What are the valued life activities that they can't see themselves doing successfully? And that's what Carol was doing. And so then you ask them to show you, what are the things you have trouble with? What are the things you'd like to do? Show me. In a way, telehealth has been the greatest boon in the world, because we're in people's homes. So they can show us, well, I have trouble getting the rice out. I have trouble with the pot. I have trouble tying my shoes. Finally, a real assessment of what matters. Long answer, I'm sorry.
No,
I'm so sorry.
No, that's what we're here for. So.
I'm so sorry.
You've been since I've known you, which has been about 20 years, very anti-guru, is I think how I've heard you say it before. Why is it important in your mind that you don't put all your eggs in one basket and we're pulling from multiple different modalities and treatment ideas? And I mean, you've really stretched across the world of training, manual therapy, rehabilitation, physical therapy. I mean, you're really pulling from a lot of different places.
I listen to to Taylor and you speak to PJ Manville, who I have so much respect for because he's mild-mannered. He is not a person who is selling any athlete about anything. He stays in his lane. Yet he has this passion for knowledge, which is what I learned from Levitt too. Keep an open mind for new ideas that sometimes show what you thought or believed before was wrong. PJ personifies humility. And in so doing, he personifies uncertainty. It's complex. We don't have all the answers. So, to your point, putting your eggs in one basket is the height of foolishness and arrogance. Levitt pivoted till, by the time I was with Carol and Vlad, Carol was doing more rehab and Yonda was doing more cavitation.
Yeah, they flipped.
They flipped. And Levitt wouldn't teach us some of his newer hands-on things, which he learned from the osteopaths, because he hadn't used them for long enough. So out of respect to the Greenmans of the world, the osteopaths who developed the fascial techniques, he wouldn't even teach us what he was experimenting with until like maybe 10 years. And at that point, like every year of his life is like so vital because now he's 80 years old. But he became gentler and gentler and more attuned to self-management and what a person can do for themselves the older he got. And I found that it became a really comfortable thing for me about 5 years ago to be able to say I was wrong, I don't know, etc. To your point, so why wouldn't I want to be a learn-it-all, not a know-it-all? Being a know-it-all is the height of boxing yourself into a corner. It's foolish. You got to keep all your options open. And it doesn't mean that you should be without an opinion. So I don't know if you're familiar with Matt Jordan, but Matt is a PhD coach in Calgary at the leading think tank and Olympic training center for Canadian Olympians, mostly skiers and jumpers. And Matt talks about prediction in a very humble way. And he says, predicting injury is like predicting the weather or predicting a hurricane. So you really can't predict these adverse events like a hurricane. But the more data you have, the closer you are to the event, the better your forecasting will get. And so he's one of these people where he wants to collect data, but he's very humble about all the data. So he doesn't get overwhelmed, like maybe in some sports, like in basketball, there's professional soccer, Manchester United, so much GPS data, like they're overwhelmed. It's a tidal wave. When I was in the NBA, we had 5 video guys. Now there's like 10 data managers. And you were speaking with Michael Gervais today. I've been with the Seahawks, and I was with them when they first started to bring in, before Pat Ward was there, when they first started to think about, well, we need screens and countermeasures, and we're getting all this data, and how do we know what counts? And so they were drawn to like FMS and DNS and McGill because they thought that there's screens that lead to countermeasures, and they wanted the so-called correctives. Obviously, I'm with my fingers to those of you listening, doing the quotes because we can't say with certainty. So why wouldn't I want to be a learn-it-all? Why wouldn't I want to be humble? And now with COVID, like when else have we had this opportunity to update our priors like this? And we had racism wrong. We thought that civil rights with the 60s made progress. We didn't make any progress. We institutionalized it. We have institutional racism now. So Jim Crow lives on. Like now, in the last year, we now have been able to evolve 10 years in 1 year because now our eyes are wide open. And I think that's true in all of our fields. When I think of biomechanics, like I was all in love with biomechanics and knowing mechanisms of injury and how to position people for success and find the cause of non-specific back pain. What a lame label, non-specific back pain. Actually, non-specific back pain is a beautiful thing to tell somebody. You don't have a sinister problem, and you're not going to need surgery because you don't have the only thing we can diagnose other than a tumor infection or fracture, which is a compressed nerve. What you have could be due to multiple things, all of which have a positive prognosis. And there's so many possibilities that we have an infinity of entry points. So if one thing doesn't work, we're going to do something else. So complexity is our friend, which is what Tasha Stanton talks about, who is absolutely an amazing person on this area of turning complexity on its head. So complexity and our inability to find a precise pain generator actually becomes a positive thing in how we manage things. So we become like PJ. We become humble, we don't overpromise people, and then hopefully we can exceed expectations.
So we talked about Yonda, Levitt, and their influence. I know Stu McGill's had a huge influence on you. So can you kind of talk about the timeline of when you met Stu and how that has changed your paradigm?
I do go pretty far back with Stu. So I was lucky that in the early 90s, Stu and I were on parallel paths. So he was getting his PhD when I graduated chiropractic school. He was... as he tells it, getting beaten up by people like Harry Farfan. He was looking at like Rakovetsky's work and realizing that the spinal engine was a theory only, and as mesmerizing it was, as captivating as it was to a lot of osteopaths and chiropractors, it actually had too many holes in it for him. And so, Stu began trying to figure out a model for modeling the spine from an engineering perspective and determining the role of different muscles so that he could find out whether or not certain exercises actually were appropriate for, let's say, A, performance, and B, rehab. And so he developed his formula for high muscle challenge, low joint load, and he found, sure enough, there's a heck of a lot of things that are done like a prone Superman, which have high muscle challenge and high joint load. Therefore, they don't make sense for an acute back pain patient. And there were other novel exercises like a bird dog, which have high muscle challenge and low joint load. So the ideal ratio is high challenge, low load. High muscle challenge, low joint load. What's non-negotiable about Stu is finding things that are high muscle challenge, low joint load early as a ramp. What I would say is a pivot for me in the recent last few years is I think that telling people that these other exercises are dangerous was a nocebo. And telling people that you could find a specific cause of non-specific pain was also a nocebo, because it begins sort of the holy grail and it feeds people's worst tendencies of wanting to know something that actually you can't know.
Right.
And then you start in this search like, oh, I heard it's my psoas, and Joe Rogan talks about the psoas, and and it brings out the worst in people. It's a noble thing because we know people aren't happy with the label. And that's why Tasha Stanton gives us a new perspective on the label. And I think that as a biomechanist, Stu at his very best is in a room of clinicians, and he says, you guys are the clinicians, tell me what you need help with. But at a certain point in time, somebody like Professor McGill actually becomes a better clinician than the clinicians, so he may not ask that question anymore. And now people are spending thousands of dollars and flying across the globe to see him. But for you, Brett, or for me, we're going to see the person again. And it's not as expensive to see us. And so whereas he'll have follow-up, our follow-up may be a little bit different. Maybe now not so much because of COVID. But I think that there's something about a chiropractor or a physical therapist's training that's different from a non-clinician. And I think some of that has become clearer more in the psychosocial realm. And now what I realize is that we don't have all the answers. And what a really great chiropractor or physio does is they build up a relationship, a rapport. They give tangible hope and an achievable plan, and they're able to guide people, and they identify when somebody is overprotective, and they address the overprotection and the anxiety and catastrophizing, and they identify when somebody is not a good pacer, and they teach them more about maybe you need another week, maybe you need more of a deload. And this is sort of still staying in our lane. We're not becoming a psychologist. They call it PIP, or psychologically informed practice in physical therapy. It's been around over 10 years now, and some people criticize it because they say that the psychologically informed physical therapy practitioner is telling people the pain is in their head, which they're not doing. That's a rhetorical argument, and somehow we polarize biomechanics, not McGill, but biomechanics, and pain science. And that was a false dichotomization. Okay, it was never accurate. Peter O'Sullivan and Lorimer Moseley weren't perfect, but they never said that you should tell people that the pain is make-believe or imaginary or they're conjuring it. In fact, Lorimer said the opposite. He said that we need to validate pain. And that's an important step in relationship building and in building trust, is the first thing you do with a basket case, with somebody with persistent pain who's in a tragic situation and they're disabled, is you validate their lived experience. And you don't tell them you're going to find the cause of their pain. It's certainly not mechanical. They've already had 100 other people, okay? You might get lucky, but the odds are stacked against you. The reality is that maybe it's more of a Tim Gabbett thing. Maybe it's more of a sports science thing, where it wasn't the activity that broke them down, it was the activity they weren't prepared for. And now they're more underprepared. So they were overprotective, and now they're underprepared. And I think that's the bringing together of these worlds of mechanics and pain science, is when you put Tim Gabbett into the mix and you bring sports science into the pain science and biomechanical science terrain. Now we can see why we don't do so much passive care, why it's only a catalyst, why we teach people self-management, why we reassure, why we reactivate, why we build resilience through robustness and GPP and adaptation, and why variability is our ace of spades for thinking outside the box when those other things aren't getting the job done.
As you're not relying so much on passive treatment, what does a treatment plan look like with a typical patient for you? When do you like to follow up with them after the initial assessment, or is it just completely case
good question? Taylor, you should ask that.
Well,
That was a hell of a fucking question. So that's the best question. The follow-up is the following morning. So, again, when we get past the tyranny of the visit and the dependence on a fix-it model, on mechanics or manual therapy, which are great things, but they're only part of the armamentarium. We realize that the most important thing, again, is hope and validation. And when I say hope and validation, I'm really talking about the difficult cases, the ones that have fallen through the cracks. And I'm not going to promise the moon to those people. That's arrogance. So we have to validate their experience, their lived experience. We have to know their story. And we have to be able to give them hope. And they're persistent pain patients. Like, why would they have hope? One of the ways that we give hope is by telling them up front that whatever positive experience with movement they got on day one, which is the goal. It is the goal, day 1, day 2, day 10, day 100. A positive experience with movement. That's our credo. That's the first principles of movement, sine qua non. Okay, non-negotiable. Give a positive experience with movement. It may mean developing failure tolerance. It may mean realizing that not every hurt equals harm. You can have a positive experience with movement when you don't think hurt equals harm. That's 1983 evidence-based spine care. Number one is reassurance that hurt doesn't equal harm and activity isn't dangerous. That's bucking the status quo. That is the guidelines that have been disseminated and not implemented because it's against culture. Until the Twitter storm accompanying the 3-part Lancet expose, we didn't have any cultural countermeasures for why hurt didn't equal harm or activity is safe even if it's uncomfortable. But yet those were the first 2 pillars, the bedrock, the keystones of evidence-based, not just spine care, but it's actually, we're out of our silo now. We have Jeremy Lewis and Peter O'Sullivan's paper on breaking the silos. This is for all musculoskeletal pain. It's not just for back and neck. And so we know that reassurance and reactivation is the key. Therefore, I have to debrief the next morning. Because if I'm talking about the basket case, they're prone to anxiety, prone to catastrophization, they're overprotective, they're armored, they're They're hypervigilant to pain. They're very sensitive. Even if they had a positive experience with movement, I'm sure that it was uncomfortable. So I have to debrief with them, which I never thought of doing until I'm hanging out at Exos and Altus comes over to Exos. So after being at Exos for over a decade, Altus shows up with Dan Paff and Stuart McMillan. And Dan is talking about the debrief. And he says, none of my elite athletes go to Rome or go to Tokyo or go across country without us touching base the next morning. I want to know how they slept. I want to know what the hotel room is like. I want to know what the gym is like. What does the field look like? What does the practice area look like? Do you know what time you're going off? When are you warming up? He does a debrief. And that's when the wheels started turning, because that was another thing, like forgetting about the importance of sensory afference to the motor axis for Yonda, forgetting about Levitt's emphasis on the history. Damn it. Levitt talked about the debrief. He didn't call it a debrief. Later, I called it an audit. It's MDT. It's McKenzie. Okay, it's empiricism. He didn't call it an audit. He didn't refer to McKenzie in the best of lights. But he talked about empiricism and having to go back and circle back. We always have to connect with people again to see how it was. How did it go? Any other questions? Like motivational interviewing. Is there anything else? Did I get it right? Do you want to add anything? Are you sure? So for Levitt, circling back, he might have found a blocked fibular head and a trigger point in the QL, and he's doing some foot training on the person, and then he circles back and checks the fibular head and goes into the QL harder than he did before. And they're like, are you on the same spot? And he goes, well, am I pushing harder? They go, yeah. Does it hurt? No, it doesn't hurt at all. Are you on the same spot? Like, they can't believe him. But he has to circle back. He has to debrief. And so we also know the debrief is the story. So we have to debrief the next day. Do they know how many reps they're doing of the self-care? Were they able to open up the videos that we put on their phone? How did they sleep? Did anything occur to them that they didn't share with us before? That's of importance. So when do we follow up? It's concierge. This is the new era. It's all concierge. The first visit, they're paying for concierge. And I want them to know that if they have a question, I want them to text me. I want to hear from them. I don't want people to have a flare-up and not tell me.
Or go to ER, or, yeah.
Or go see the other guy.
Right.
I want them to expect failure. So this is what we started with failure mindset. Failure tolerance. This is Annie O'Connor 101. This is Rachel Balkovec 101. This is Carol Dweck, the book Mindset. It's Angela Duckworth, Grit. It's failure tolerance. Flare-ups are expected. If you're a persistent pain patient, like, it's just
count on it. Yeah.
It's just when. So I want them to expect it. They didn't think I was fixing them. Not a cure. It's a program. It's a process. And I want to anticipate flares. I want them to know to reach out to me when they have a flare. So debriefing is an ongoing thing, and Dan Paff is the godfather of the debrief in performance. And then we're working it out in the rehab area.
What about, so we talked about, let's just say manual therapy. Let's go down the manual therapy route. So where does...
Back to passive care.
That's
I can't
right.
let it go.
Well,
Grip it hard, baby.
We know that you're not doing any passive care in your life, because there's got to be a room for it somewhere. So what patient profile, where do you use it? Where in your day-to-day life is
The
it
age-old question, what are the indications?
Well, it's hard because Levitt used it, so...
Yeah, he did. So I had it wrong. I became kind of like a McKenzie person and started to believe behaviorally that it's last. That when the person's finger is in the flame, you don't pull it out, they have to pull it out. And then if the McKenzie stuff needs a little push, then you can do some manual therapy, or if it's not working, you can do some manual therapy. And so I gravitated towards self-management and self-care with more and more tunnel vision. And when COVID hit, I was like, yeah, awesome, no more manual therapy. So it's off the table. So the tyranny of the visit is now in the rearview mirror, and now people that are expecting a quick fix no longer can expect a quick fix. They're looking for other options. And now we get a chance to build relationships and rapport. We get to teach them the power of self-management. And we get to really eclipse their expectations, and they go, wow, this is not what I expected. And so I did a high-value prehab rehab webinar series for 12 weeks, consecutive Sundays, when the pandemic struck. And in it, we talked about Batman versus Alfred. And Alfred is guiding by the side, and Batman is being the hero, okay? And obviously it's a fix-it model. And we contrasted them and really talked about avoiding that temptation. And now it's easy to talk to people who are great with FMS correctives and all these algorithms, SFMA, different systems where you see this and you do that. Very linear, unidirectional kind of bidirectional thinking, not complex systems theory stuff, not a web. And we were able to take a step back and take people on a journey through complex systems theory and dynamic systems theory and the birth of computer science and things like that, and taking an approach that values, like investments, optionality, where you to really have a sustainable approach. If you're putting your eggs in one basket, okay, you're risking losing everything. Whereas if you have optionality and you just take risks judiciously, now you have a hack for long-term sustainable success. And that's something that you can have confidence in. So we loaded up on Alfred, on guiding by the side, and then after the webinar series was done, I decided to do a sequel, and it was on knowledge translation. Because just like everything else I've ever done my whole career, everybody takes the fucking courses. Can I speak?
Oh yeah.
Yeah, oh God, please.
And then they go back to their environment, and they go right back to the status quo. Cognitive dissonance takes over again. Vested interest. I can't get paid for this. I don't have time. They go right back to their old ways, right back to the status quo. And they go, oh, the course was great, but don't know how to use it. All made sense, don't know how to use it. So implementation. So we realized the same thing was going to happen again. There was going to be this upskilling of knowledge, but there was going to be low implementation. So we decided to do a whole gig just on knowledge translation. And the kickoff speaker was Jan Hartvigsen, who's the chiropractor on the Lancet group of authors. Brilliant, visionary scientist. And he started off, and what did he do? He completely stabbed me in the back, I thought. He's talking about manual therapy. And this is the guy behind the GLAD work on OA of the hip and knee, all active care, group training. He's all about self-management, and yet he starts off and all he's talking about is manual therapy. And I had thought from Lancet that manual therapy was low value. And he says, yeah, that's what we called it, but that was a mistake. So he disagreed with all of his other co-authors, Rachel Buchbinder, Chris Meyer, like legendary, just heroes of the science of evidence-based spine care. And he said low value was a poor choice of terms. That it's not the lowest value, it's not the highest value, it's adjunctive. And we all know if something is adjunctive, that A, it could be a catalyst, so you might do it first. B, it might be your first go-to if something else isn't working. 3, based on patient preference, it might be your first thing. And so I changed my whole view of manual therapy very, very quickly, just about 7 or 8 months ago, thanks to COVID, because of Jan's talk. Never forgot that talk. And so if I uncover in your story and your history that you have a preference or you have a high-level expectation, I don't care what it is. I don't care what K-tape, dry needling, I don't care if I don't believe in it personally. If you believe in it, it's more likely to work. And that gets to Michael Gervais. So one of the most important things that I use as a GPS is this idea of confidence. And as Michael says, confidence is the cornerstone of great performance. And it comes from one place, from what you say to yourself. So if a person is already, I want to know what they're saying to themselves. I want to know what their mother is saying to them. I want to know what the other orthopedist said to them, what the other chiros. I want to know all the things that they believe. I want to know all their beliefs. We now know how important beliefs are. That's why the history is so important. I've got to hear their story. I don't want to interrupt them. I want to hear what they believe. When I know what they believe, then and only then can I begin the process of trying education. But education is not about me teaching. As Mosley says, we all think education is simple. Education is the hardest thing of all, and none of us are trained in it. Education doesn't happen until they learn, and most people won't learn until they're in a fragile state. And you know, Brett, you know when somebody is receptive. Mm-hmm. You are a savant at reading these tells when you know their mind is opening up. Mm-hmm. And you know like what they would be receptive to. Is it a chiropractic adjustment? Is it soft tissue? Is it FRC? Is it DNS? Is it a mechanical explanation about, well, of course, you're butt winking, look at your squat, you'll know when to give what. That's why you have a gift, okay? Not everybody can do that. And so all the novices are like, well, I need a formula. They're not a savant. And so they want recipes and protocols. And my point to the students at Parker and all of the young PT students is don't drink that Kool-Aid, because you never want to accept that protocols are the answer. You always want to get the story from the person, and the story from the person will give you your muse, so you're a miniature Brett Winchester.
So it sounds like then what's hard, I think, is for our students, though, is like they need some baselines. You know how hard learning is if you don't. I mean, you can, the first time you went to Prague and you could just get inundated with all this information, and sometimes we're frustrated because we don't know what the baseline is. So how do you reconcile that, where you got to start somewhere? You can't tell a first year student to walk into a new patient with a clean sheet of paper and So when do systems become restrictive? When do we use systems? Everyone's benefited from Gray Cook and FMS, SMFA. I don't know. What do you think about that?
I think you need a template, but I don't know that you need a system.
That's a good word.
That's good.
I think you need a process. Mm-hmm. And I think the process becomes with enhancing the appreciation you have for the person telling you their story and listening. Mm-hmm. The most important technique you can develop is communication. And I know I have friends with the OKC Thunder, and we would sit and talk about their players, and they would share with me that the most important thing for them wasn't what they did in the training room. The most important thing they did with them was sitting and just having a conversation with them. And I've seen Ken with the D-backs. Yeah, he's doing the soft tissue, but he's really building trust. Mm-hmm.
Yeah,
that's what he's really
good listener, and
he's a great listener. And PJ, oh my God, there's no better listener on the planet than PJ Mandel. Mm-hmm. So I think for the newbies, acceptance of uncertainty. Number one. Number two, valuing the history more. The most important technique is going to be communication, and the most important part of communication is going to be listening. And specifically, learn about the psychology. You're not a psychologist, but there's a lot of psychology in this. Oh, yeah. Pain is a sensation. It's a feeling. It's like thirst. It's subjective. So you have to validate it, and you have to give them hope, and to do that, you got to hear their story. It has to be their story. It can't be your story. So not interrupting people is really hard. Doctors, we thought, interrupted every 18 seconds. It turned out it's every 7. Now, a chiro and a PT has to learn about psychologically informed practice. And so the way you get started is, of course, you need to have like a child. You need to have broad knowledge. So students should all be like Brett Winchester. They should all be like Roy Page. They should have broad knowledge. They should pursue knowledge about motivational interviewing, about empathetic listening, about grit, about resilience, about confidence. They should listen to Michael Gervais' podcast. They don't have to wait till they graduate. They can get all that stuff for like under $100. They should get broad expertise in a number of methodologies. So if they learn a little bit about PRI and a little bit about DNS and a little bit about Olympic weightlifting and a little bit about FRC, now they have optionality. Rather than doing 10 PRI courses and going down the rabbit hole, better to be like a sharpshooter and look out from the hole rather than go all the way down the hole. Like a youth athlete. The youth athlete who super specializes too soon is going to burn out, and they're going to have injuries, and they're going to wind up taking drugs before they're 18. And I don't mean performance enhancers. But we now know the value of generalization and play when somebody is learning. So 6, 7, 8, 9, 10-year-olds need broad exposure. I hung out with the greatest Czech hockey player before Jágr, Peter Svoboda. And I think Peter scored the winning goal against the Soviets when Czech Republic won their first gold and only gold. And he played soccer growing up, and he rued the fact that, and this is 15 years ago, Peter telling me this, he rued the fact that hockey players in the Czech Republic were all specializing young. So they didn't psychologically understand the different requirements and strategies needed from different sports like soccer or tennis to apply to hockey. And he had that, and that helped him think outside the box and become a Hall of Famer in hockey, as well as prevent injuries. So the youth need generalization, not specialization. And I don't really see where protocols and recipes factor into any of the things I just said. I think if you value uncertainty, if you know how to listen, if you know the basics of motivational interviewing, if you have broad exposure to manual therapy options and strength training options, then you got a lot of bullets in your gun. And you, like Michael Gervais said, should have confidence. And you'll be just fine. Confidence is the cornerstone of great performance. So your diploma should be the president of the school telling you that you should be confident because you had that broad exposure. You've checked all those boxes.
I don't know where you got it, Craig, but I heard you speak at Parker not that long ago and use the term gamification, which I don't know if that's your own thought or if that was someone else's, but what I really liked about it is I thought, like, in the world of rehabilitation and training, I think that's so, like, critical for patients. Like, if it can be fun for them, and I've just never heard it termed that way. I thought that was, like, just such a great term.
It's not mine.
Okay. So, but I think...
I'm a thief.
But what a difference it makes when there's a game to it. It's just human nature, whether that's gambling, whether that's competing in sports. Like, if you can make rehabilitation fun and gamify it, as you said it when I heard you say it, like, I think that's a critical part that not that many people realize, like, how important I think that is. It's everything. Yeah,
it's everything.
Yeah.
Yonda knew that. So it comes from game theory. It comes from behavioral economics. So in game theory, the whole thing is about stickiness. So like in brands, there's a thing about making a brand sticky, and you want concepts to be adhesive. You want to have nudges, so we know about habit formation, and we know that like you can't attack the physical inactivity crisis by telling people what they should do. Language that requires you to moralize to people is not going to change behavior. The hardest thing is changing behavior. Stephen Hawking, before he died, recorded a 57-second video, and in it he concludes by saying the cause of most disease is we move too little and we eat too much. And then he pauses, and the camera zooms in. He's like in the library at Cambridge. And he concludes by saying, and why it is more people don't realize this is beyond my comprehension. Smartest man in the world. Succinctly, 57 seconds. He's correct, obviously, but also what he didn't understand was psychology. We do know why people are going against their genetics. Of course, our genetics are to crave food because we grew up with scarcity. Before there was Homo sapiens, hominoids, 7 million years ago. This goes back, I mean, we're only 200,000 years old as a Homo sapien. But hominoid broke off from chimp and gorilla 8.5 million years ago, let's say. We've always craved food. Now you just go to the refrigerator. So of course we're all overeating. Rational ideas about you shouldn't eat so much are not going to change behavior. Similarly, we're designed to conserve energy. So telling somebody, oh, your back will feel better, your hip will feel better, you'll lose weight if you exercise more, you should do 30 minutes a day, 5 days a week, and twice a week of strength training. It's not going to change behavior. The foolishness is us thinking that that's all we have to do is educate. Education doesn't equal learning. So we need all this behavioral economics, we need game theory, we need nudges, which are specifically constraints. They are guardrails. So when you create a game and you make it a competition and you tell adults to play tag, or you time somebody like my older sister did with me, Craig, I'll time you. Go get the mail.
You fell for that?
Last time it was 30 seconds. Go. I'm off and I'm running so hard. So we give people external cues, not internal cues. So that's part of gamification. Is focus on how high you can jump, not focusing on use your glutes more. Okay. Focus, and one of the people that introduced me to this concept that got me going down this rabbit hole was Stu McGill. The irony is that Stu mentioned gamification because he had come across Gab Wolf. And Gab Wolf, of course, Nick Winkelman has made her really famous, and Nick and I have talked a lot about this. I've been interested in this for a long time. Gab Wolf summarized and did some of the most important research on external versus internal cues. One of the best examples is basketball. We know that the basketball player who just keeps shooting free throws isn't going to do better in the game. Okay? It's not going to affect choking whatsoever.
Check.
What they've started to do is blast alarms, turn off the lights. Make guys shoot free throws after somebody throws them a bounce pass, then a chest pass, then a bad pass. Has like a clock going, and they hear the clock in the middle of their free throw. Variability, back to variability. So external cues, variability, gamification, a reward for getting so many things done correctly in a certain amount of time, competing against another person. Just a constraint. So doing a squat like McGill teaches against a wall, that's game theory. Now you can't butt wink. When you squat in the window pane squat, maybe your depth isn't so great, but you can't butt wink. So if somebody is a sloucher or a slumper, have them squat against a wall or do a TRX squat. Now I don't have to coach them. The environment is the coach. So we have the environment and we have the task and then we have the person. And Yonda knew all about game theory long ago. He wanted the rocker board because it was fun. And he didn't ever believe in voluntary exercise. In fact, he told us don't give a cortical exercise. So when people say that DNS is Prague School, DNS is not Prague School. Vojta left Prague when the Russian tanks rolled in. This is a moral question. This is about morality, okay? Vojta left. Now, it wasn't really bad that he left. I don't want to judge him bad and Levitt and Yonda good, but Levitt could have left at any time. He had a British wife. He could have left Prague before the Prague Spring, which is when their rebellion was hopeful. That's why it was the spring. It was called Prague Spring. It was a hopeful rebellion against oppression. And the Russians rolled the tanks in from the Soviet Union and suppressed the rebellion. Levitt could have left at any time. British wife meant he could leave at any time. Yonda was not allowed to go to the programs at Michigan State where they were talking about manipulative therapy because they were afraid he would defect. So his presentation was in absentia. Vojta chose to leave. Vojta, for whatever reason, set up the institute in Germany and then an institute in Rome. And Pavel is a student of Vojta's. Pavel was never a student of Levitt or Yonda's. When we talk about the Prague School, we're not talking about Vojta. Vojta was a neurologist who treated CP. The Prague School we're talking about is the Prague School of Manual Medicine and Rehab. We're talking about the school that Levitt and Yonda formed under Yerut, who was their teacher, and alongside Vele and others. And so when we say that DNS is Prague School, DNS is an amazing thing. It ain't the Prague School of Rehab. It's cortical. That has nothing to do with what Yonda was teaching. Yonda said minimize the cortical stage. Training should be subcortical, which is game theory. Biomechanics and McGill's work also, he introduced me to game theory and gamification through Gab Wolf, yet there's a lot of internal cues in the way they teach some of like the bird dogs and side bridges. There's a lot of hands-on, there's a lot of pre-positioning, there's a lot of internal cues, none of which is gamification. Gamification is only external cues, or primarily, and using the environment to steer movements so that people have a positive experience with movement. And they problem solve on their own so that it's sticky. None of which is a criticism of mechanics or ontogenesis. It's just accuracy for the record.
I love it.
Yeah, that's perfect.
What a great little sum up there, Craig.
And I
That's
love
amazing.
mechanics.
Yeah.
Like, we can't throw the baby out with the bathwater. I believe in mechanisms of injury.
Sure.
And none of which, as I said, is a criticism of ontogenesis. The story of how a child progresses to the 13 or 14 month position in the sumo squat is a spectacular story. I happen to prefer the story of healthy longevity, and I like reverse engineering more, which is just my taste. I like to give people something aspirational. So we know that a 90-year-old will lose their independent function if they can't get up and down from a toilet unassisted. And we know that a 75-year-old has a 400% greater fall risk today than in the year 2000. And not because there's 400% more 75-year-olds. It's not because we're living longer. It's per capita. Why is that? Well, we're managing people away from load. Hawking already said it. We've become sedentary. Who said that first? Yonda.
Hawking also said there is no way 100 years from now that humankind is on planet Earth.
Oh my God.
So it might not matter.
Yeah, exactly. Well,
So I prefer the story of healthy longevity, and so I prefer to give people something aspirational. So I want you to be able to squat. I want you to be able to get up and down from the floor and not have a fall when you go downstairs where there happens to not be a handrail. I want you to have that ability. I want you to have the strength so that osteoarthritis isn't disabling when you're 50. It is not normal to be disabled by OA at 50. A 50-year-old today is older than a 50-year-old was in 1940. A 50-year-old today is older than a 50-year-old was in the industrial period, and a 50-year-old today is older than a 50-year-old woman was 7 million years ago, and that's a fact. We know that from Dan Lieberman's book. His new book is Exercise, but his book, The Story of the Human Body, describes in detail the research on this. We have fossils. There is less arthritis 7 million years ago. There is less arthritis from the bones in the industrial page. There is less arthritis in the x-rays from the 1940s. What has changed? Well, Hawking told us. We move too little and we eat too much. So we have this pro-inflammatory cascade. And then what are we told? We're told to be wimps. We're told if it hurts, don't do it. We're told let pain be your guide. That's the opposite of Michael Gervais. Mm-hmm. There is no resilience anymore. So we're creating fragilistas. So if you look at Taleb, we need optionality. We need to question the status quo and think outside the box. And we need to realize that to create a bulletproof human frame, atrophy is a law. At the age of 31, we're starting to lose muscle mass. It's not measurable. By 40, it's measurable, 1% per year. By 70, it's 1.5% per year. It's also something you can prevent. And in a 75-year-old who's been inactive for 20 years, which is 81% of 75-year-olds, okay? Or maybe more, it's probably 85, 90% of 75-year-olds. It's reversible in 3 months if you follow the WHO guidelines. It's fucking reversible. But we can say this, nobody's gonna change their behavior until we have no car zones. It's a policy issue. Until we have chiropractic schools that are learning to teach more about GPP and less about manual therapy. Until we have physical therapists that aren't managing people away from load and babying them. Until we have doctors that are scanning less and appreciate that exercise is medicine. Until Lancet has another Twitter storm about physical activity and obesity and arthritis and back pain, so that we can begin to change the conversation culturally. Then when we listen to people's story, it won't always be about, I was told that I shouldn't do it if it hurts, and I was told I need to scan to find out the cause, and I was told that I need to work my core or my psoas.
Well, Craig, I think if I could just sum it up in one thing is build positive movement experiences with each and every one of your patients, build resiliency, and encourage them to live the lives that they should be living. And so be a positive influence with them. And we thank you for your contributions. Not
You have
only
to add, don't be a prisoner of protocol.
don't be a prisoner. That's right.
Levitt said it more poignantly. Don't be a slave of methods.
Mm-hmm.
The method should serve the goals.
Right.
And we would add to that whose goals? It's the client's goals.
Mm-hmm. The patient. Yeah, absolutely. Well, thank you, Craig, for letting us sit down with you and for picking your brain. And if you haven't already checked out the new edition of Rehabilitation of the Spine, it's incredible. It's got features one of our very own, Brett Winchester. It's not a very good, not a very good one, but
well, I remember the Blue Book changed my life. Did that come out in '96? Was that the 96?
Yeah, first edition, blue, 96, and then the grievous error of the second edition, which was all on motor control and corrective exercises, was early 2000s. And that's why we had to change the title for the third edition from a practitioner's manual to a person-centered approach, to update our priors.
To encompass, yeah, exactly what you're talking about. So, all right, we're out of time. Thank you guys so much. We learned a ton today,
Thank you.
I'm guaranteed there'll be more in the future. So, appreciate it.
Thanks for the vine.